Good afternoon, doctors. Thank you very much for joining us today for this webinar, which is a part of the series started by Professor Dr. Y R Yadav, titled as Professor Dr. Y R Yadav's Neuroendoscopic Surgery, series episode 7. And today's topic is endoscopic management of pituitary tumor. This series is coming to you through a digital initiative by Health and You, a joint venture with New Link Company Limited, Japan. We have some innovative products because our vision is to fulfill unmet medical needs. We have for migraine and painful nerves Amnurite, a unique combination of amitriptyline plus mecobalamin, Amnurite 5, 10 and 25. In migraine with comorbid condition, when one drug is not enough, we have Amnurite beta, amitriptyline plus propranolol combination, Amnurite beta 520 ER, 1040 ER to beat headache together. In low back pain, we import mecobalamin injection from Japan, Neurite injection, the one and only made in Japan injection for mecobalamin. In severe neuropathic pain, we have amitriptyline plus pregabalin given in a sustained release form to match pharmacokinetic profile of amitriptyline, Amnurite-P, so that your patient can get 24 hours pain relief. In migraine, we have American Academy of Neurology supported vitamin therapy for migraine, first time in India. Riboflavin 200 mg, magnesium 200 mg, and CoQ10. Brentamine, vitamin therapy for migraine. And in step-ladder treatment of epilepsy, we were the first one to launch 2.5 mg of clobazam, add clobaz to add flexibility and add control in your epilepsy therapy. Clobazam mouth dissolving tablet, 2.5 mg, add clobaz 2.5, add clobaz 5, and add clobaz 10. Our webinars are available on DigiNeuro channel of YouTube. So today's webinar will be uploaded tomorrow, and all our past webinars of Professor Dr. Y R Yadav's webinar are available on this channel. We have more than 35 webinars on this channel. You can just go on the YouTube and type DigiNeuro and you will get the resource. Most of them on neurosurgery by experts like Dr. Professor Yadav. Now I have great pleasure in introducing today's coordinator, Dr. Shailendra Ratre. He is MS MCH Neurosurgery. He is Assistant Professor, Associate Professor of NS Superspeciality Hospital, NSCB Medical College, Jabalpur. I have great pleasure and privilege to give this session to Dr. Shailendra Ratre. He will take it forward from here. Professor Ratre.
Thank you, Nayak sir. Good afternoon, everybody. Good afternoon, Yadav sir and Mr. Nayak. And today I am having great pleasure to introduce Yadav sir. Yadav sir needs no introduction in the field of neurosurgery. Sir started in NSCB Medical College, Jabalpur from 1992 as assistant professor. And at that time, there was no department of neurosurgery. There was no OT, no wards, no facilities, and no instruments as well. But sir crosses all the hurdles. Gradually, sir started doing surgeries with all hard work, and gradually sir had established a OT, a department, and sir has started doing endoscopy. And in the year 2010, sir started the prestigious neuroendoscopy fellowship program, which is organized by sir biannually, and sir is the course director. And after that, gradually we take the neuroendoscopic fellowship from the university, Madhya Pradesh Medical Science University, and we are getting 2 candidates per year. And after that, we have got a Superspeciality Hospital from PMSSY Phase 3 scheme, and presently sir is the director of that Superspeciality Hospital. And under this hospital, we are running 9 super specialties. And sir is also the director of upcoming School of Excellence in Neurosurgery, which is the only state-of-the-art institute in the MP, and which will start very soon. And sir is the executive member of executive committee member of NSI, and there are many awards under his name. And sir is many innovations. Sir has more than 250 plus publications in international and national reputed journals. And we are going to publish textbook which is comprehensive textbook in neuroendoscopy, and which will be publishing very soon. And one thing which I want to say that sir has all the qualities, was one thing which we are seeing regularly, that sir is one of the best teachers today in field of neurosurgery. And we have also started MCH under guidance of Yadav sir since last year. So we have now fulfilled department with all the facilities, and we have guidance of Yadav sir. So without taking much time, now I request Yadav sir to start this webinar, sir. Thank you.
Thank you. Thank you, Dr. Ratre, for nice words. So what I'd like to say is that whatever small little we could do is all because of teamwork. And I'm lucky to have persons like Dr. Ratre, Dr. Parihar, Dr. Narayan Swamy, and my all colleagues. So it is all teamwork. I mean, one can guide, but it's all teamwork. So thank you very much. So we start with our today's topic, that is endoscopic endonasal surgery for pituitary. Endonasal transsphenoid is the surgery which is performed through the nose, as the title suggests, and through the sphenoid sinus. And if you remove a pituitary tumor, then it becomes endonasal transsphenoid pituitary tumor surgery. You can do many more surgeries through this route, through the endonasal approach, through the sphenoid sinus, or you can extend the approach anteriorly or posteriorly. So many variations, extended approach also can be done. But this is the main surgery, transsphenoid surgery. Has a lot of indications, and out of these, one we will be talking the pituitary surgery, which is the most common surgery. This transsphenoid surgery can be performed through the endoscope, or you can use microscope, or can take help of both. You can use microscope for most of the time and can take the help of endoscope as and when required. So initially, most of the surgery was done through the microscope. Now, because the endoscope allows better visualization, therefore you can perform things better. And there is no doubt about it, although there are many debates are going on still, but I think now everybody agrees that transsphenoid surgery using endoscope is better than when you use microscope. It is often a teamwork in which the neurosurgeon and ENT surgeon can work together, or only two neurosurgeon or a single neurosurgeon like I was doing before, because when I started this surgery, there was no other neurosurgeon with me. So you can make a teamwork, which is always better. You can have a neurosurgeon or ENT surgeon team, or you can have two neurosurgeons, or otherwise whatever way you like. But if there is a neurosurgeon and ENT surgeon, because the ENT surgeon knows better about the anatomy of the nose, so the ENT surgeon, if you have a good team, is always good, to my opinion. The indication for transsphenoid surgery is most pituitary tumors can be operated through it, and most craniopharyngioma also can be done using this approach, except when it is a pure intraventricular tumor, craniopharyngioma. In those cases, I think it is not good to to have this approach, or when the lesion is extending lateral to the neurovascular bundle. So crossing this, although there are some variation extended approach, you can go lateral to the artery or nerve, but it is associated with large, more morbidity and complication, especially in early learning curve. That should be considered as one of the contraindications. Rathe's cleft cyst also can be removed using this approach. So the contraindications are when the patient general condition is poor, or there is an infection in the corridor like sinusitis, kissing carotid. Two carotid arteries are very close to each other, so there is no place to go in between. Or the lesion is extending lateral to the neurovascular bundle. It's a relative contraindication, very high risk of hemorrhage, or conchal type of sella where it is not pneumatized well. So if you have a navigation facilities, then you can do even with the conchal type and with the experience. But it is a relative contraindication. Dumbbell shape type of the tumor with constriction due to diaphragm sella is another relative contraindication. Although one can cut the diaphragm and allow the other part which is lying superior to fall below. So even this is a relative contraindication. But in beginning of your learning curve, I think one should take these relative contraindication carefully. Now, as far as the workup is concerned, how you should go about. After detailed history, you should have the pre-operative both CT scan and MRI. Both are indicated because MRI is good for soft tissue, better soft tissue delineation, whereas CT scan will give you detail about the bony anatomy. So preferably get both the CT scan and MRI, and in these CT and MRI you should study in detail about the paranasal sinuses. You should also see whether the septum, nasal septum is deviated or not, or there is any spur which will not allow the surgery from that side, or you have to deal the spur first. Sometimes the one side of the nasal cavity is very small, other is very spacious. So before surgery, you can make out that the left side approach will be better or right side will be better. So any side which is more spacious can be used as a dominant side from where you want to go. Then you should study the sphenoid sinus with the special attention to find out whether there is any dehiscent wall, like optic canal may be having dehiscence, so there may be risk of optic nerve injury, or carotid canal may be dehiscent bony wall, so they may predispose the injury to the carotid artery. So before surgery, you should know what you will be dealing with. And there are septa in the sphenoid sinus. Most of the time, they are not in the midline. They are going laterally and attached to the optic nerve or the carotid artery. And at times, there is these optic canal or carotid canal bone is very thin, usually less than 1 millimeter. So if the septa is going there and you just avelt the septa by some forceps, then there may be chances of injury to the optic nerve or the carotid artery. So all these things before surgery, you should be aware what is happening in that particular patient. There may be onedy cell, which is nothing but a double flooring of the sphenoid sinus. So at times you find that there are horizontal floor, and these are nothing but the posterior ethmoid air cells, And if you don't remove these Onedy cells, or you are not aware of this particular pathology, particular condition, then you may incompletely remove the sphenoid sinus, and the tumor removal obviously will become, will not be 100%. You may remove incomplete because the wall itself has been removed incomplete. Or when you have Onedy cell, most of the time the optic nerve is also naked. There is a risk to the optic nerve injury during surgery. So these things you should recognize before surgery. You should identify the tuberculum celli, clival recess, and the tumor characteristic, the pituitary tumor, whether it is likely to be soft, although it is difficult to find out before surgery, whether it is a soft tumor or it is likely to be firm. If the T2 weighted picture shows hypodensity or iso-intense, then it may be a fibrous tumor. Or there are other characteristic. Nowadays, the MR elastography tells you about the firmness of the tumor. If you go the special sequence of these MRI, then before surgery you can make out that this tumor is likely to be firm. Most of the pituitary tumor, 90% these are soft, so no problem during. 10% of these may be firm, and if you know before surgery, then you can have a plan, use CUSA, or before surgery you can have a plan how to go about it. Then you should know where the carotid arteries are present, where is the normal pituitary. In a pituitary tumor, the normal pituitary is displaced superiorly or to the side. So before surgery, you can make out where is the pituitary gland, so that you can spare the normal gland and prevent hypopituitarism after the surgery. And the optic pathways, their position before surgery is very important. So this diagram shows various type of pneumatization, in which if there is a conchal type of sinus, then there will be difficulty to approach this. Unless you have navigation, it is not possible to go. So in beginning of your learning curve, you should avoid operating in such cases. There may be deviated nasal septa. In this case, the septa is deviated towards the right side, so space on this side will be less. So you can, in axial cut or in coronal cut, you can find out deviated septa, or there may be spur. The septa may be having a spur as shown here, or in endoscopic picture, it is shown here as a spur. Now, dehiscent carotid canal may be there. You may not have a bone on the carotid. So this is a carotid on this side, carotid on the other side. So on left side, there is no bone. So this, you may injure the carotid during surgery. So you should be aware before surgery what you will be dealing. Or dehiscent optic canal. So optic nerve, there is no bone. Before surgery, here again the carotid is dehiscent. This arrow showing dehiscent carotid, and here the optic nerve, there is no wall, dehiscent optic nerve. Here you can find that the septa is going and attaching to the optic nerve. So if you just catch this septa and try to avulge it, then you may produce a traction injury to the optic nerve and can cause blindness. So before surgery, you must know. So all these septas, you should not just try to avulse or pull these or twist them, where carefully to avoid the causing injury to the optic nerve, or at times the septas are going and attaching to the carotid. This septa is attached to the carotid. So here, if you avulge it, just pull it with forceps and just with incomplete sphenoid exposure will give rise to incomplete excision of tumor. Now this shows kissing carotid. Both carotid arteries are very close to each other, so there is hardly any space for you to go inside and take the tumor out. So if there are kissing carotid very close to each other, then it is a contraindication for surgery. You should also know how much is the carotid encasement or encroachment, which you can decide by the various methods which are given. Grade 0 when the cisternal carotid and the cavernous carotid, if you make a line, anything medial to this is grade 0. And if it is medial to the center of the carotid, this line, then it is grade 1. If it is medial to the lateral margin of the cavernous carotid, and then it is grade 2, 3 when it is beyond this, and 4 when whole of the cavernous sinus has been involved. So involvement of the cavernous sinus by the modified NOF classification, this we have already discussed, grade 0 to grade 4. Grade 3 can be subdivided whether it is from above the cavernous carotid or from the below. So this cavernous invasion also one should know. Then you should be able to know where is the normal carotid, normal pituitary gland displaced. Usually it is displaced superiorly or to the side or anteriorly or posteriorly. Usually it is plastered over to the diaphragm celli. So usually on the superior side, and this is the reason that why if you come transcranially, you come through the normal pituitary gland, and there are more chances of producing a new hormonal deficit, because once you come transcranially, then you first deal with the normal pituitary gland rather than tumor. So this is one advantage of transsphenoid surgery. When you go transsphenoid, you first come across the normal, the tumor, rather than the normal gland, which is when you go transcranially, this is a disadvantage. Then where is the optic chiasma present? Where is the normal pituitary? Where are the arteries present? Whether there is any encasement or not. Then whether the tumor is fibrous or not. Usually pituitary adenomas are soft, but very rarely, about 10% it can be fibrous. Whether it is fibrous or soft, you can determine by T2 weighted image. Although not always, but most of the time, if in T2 weighted MRI you find lower signal intensity or iso-intense to the brain, then possibility of this tumor being fibrous is more. And what makes it fibrous is the content of the collagen there. And another finding, if the tumor is homogeneously enhancing, then the possibility of having more collagen is high. So homogeneously enhancing rather than having a mosaic sort of, enhancement, mix enhancement. If it is a mixed enhancement, the possibility of it being fibrous is less. Whereas if it is a homogeneously enhancing and in T2-weighted, it is low intensity or iso-intense, then it may be a fibrous tumor. In which case you have to plan your surgery. If the lesion is small, then you go extracapsular. Because it is fibrous, will not suck out, intracapsular dissection will be difficult. So you find an interface between the tumor and the normal pituitary gland and take it out. But if the tumor is very large, in that case, you have to take it out piecemeal. So internal decompression first and then take out the capsule. Or use CUSA to take this fibrous tumor out, or you can stage the surgery. At times it is very fibrous, so may not be able to take out the whole in one sitting. So you might have to stage, rarely, but so if the tumor, there may be two types of enhancement. One is the mosaic sort of enhancement, just like mosaic, or uniform enhancement, homogeneous. So if the tumor is homogeneously enhancing, then it is likely to be more fibrous compared to when it is mosaic sort of or a mixed enhancement. So T2 hypointense is likely to fibrous. Contrast enhanced FASTA image are better. If the contrast and enhanced FASTA image shows uniform enhancement rather than mosaic, it is likely to be fibrous. Or MR elastography shows you the amount of collagen content. If it is more, then it is likely to be fibrous. So in MRI special sequences of elastography, if the mean value is less, then it is likely to be soft. Whereas if it is more, then it is likely to be intermediate or a firm tumor. So to summarize the workup, you should look for the septum, nasal septum, whether it is deviated or not. You should see the sphenoid sinus and the septa, whether it is going on to the optic nerve or carotid artery, whether there is dehiscent carotid artery or dehiscent optic nerve, whether there is Onody cell or not. What about the carotid, if there is a kissing carotid or not, or the distance between the two carotid are sufficient or not. What is the tumor consistency, whether it is likely to be fibrous or a soft tumor where surgery is simple. Where is the normal pituitary gland in relation to the tumor, whether it is superiorly or to the right or left. Most of the time you can find out, because normal pituitary will take more enhancement. So in contrast image, the normal pituitary will be more enhancing compared to tumor. And the position of chiasma should also be known before surgery. Now, after the workup, we will go for the procedure. Surgeon stands on the right side of the patient, and the assistant and the sister. I usually go for this kind of arrangement in which assistant is towards the head and side, surgeon, nurse here, assistant on the other side, anesthesia towards the leg end, or maybe wherever the position is. But different surgeon have a different setup, whatever suits to them. So neck position or head position, usually for pituitary tumor, it is a neutral plane. But if the tumor is more towards the anterior cranial fossa, then you can go for more neck extension. 10 to 20 degree of neck extension may be required. If you have to go towards the posterior cranial fossa, lesion going more towards the clivus, then you might have to use little more flexion of the neck. So supine position with the head and elevated so that there is no venous congestion and the bleeding, venous bleeding becomes less. So head end is elevated and the head is turned in such a way so that you can see both the nasal cavity. So from right side surgeon is standing here, you should be able to see both the nostrils. So just turn the head towards the left shoulder and rotate it slightly so that you see both the nostrils. Endotracheal tube is put on the left side. If you put it towards the right side of the mouth, then it will be coming in your way. And make sure that the sticking or even the tap should be fixed in such a way so that it does not get loose. And during surgery, accidentally, the tube does not come out. So all these things should be looked very well. Now the endoscope is stabilized at the tip and gently cranial pressure should be applied so that there is more working space. So you just fix it and just apply a gentle cranial pressure so that the space available in the nasal cavity will be more, and both the instrument can be put on either side. So one instrument here and another, both retracting in opposite direction, will create more space for you to work. Now after that, you should thoroughly inspect both the cavities, both the nasal cavity, right side and left side, and identify the normal structures and find out if there is any anatomical variations that must be seen. Identify the middle turbinate, the septa, the choana. So all these things, if there is any spur or the septum is deviated, where is the sphenoid ostium, and which side of the cavity is better, because at times the septum is deviated or maybe having spur. So identify the normal structures, inferior turbinate, middle turbinate, the superior turbinate. When you go through the inferior side of the middle turbinate, so this is the tail of the middle turbinate. Go from the inferior side of the middle turbinate, the structures which will be seen is the choana inferiorly. So choana is an important landmark. Identify the choana, the Eustachian tube. This is a tail of the inferior turbinate. And then if you move superiorly between the middle turbinate and the septum, about 1 to 1.5 centimeter, you will find the ostium, which is important for in pituitary surgery. And the other structures which you should identify, the uncinate process, middle turbinate, the ethmoid bullae, and identify the sphenoethmoidal recess. So I was saying that about 1 to 1.5 centimeter superior to the choana, you will find a ostium, sphenoid ostium. And this space is sphenoethmoidal recess, which you should widen by lateralization of the middle turbinate. So find the sphenoid ostium, which is just at the middle of the superior turbinate. And at times you don't find this ostium. So just by, about 1 to 1.5 centimeters superior to the choana, if you artificially make an opening, you will go in the upper part of the sphenoid sinus. So most of the time you will find the sphenoid ostium. Sphenoid ostium here, after lateralizing of the middle turbinate, septum, superior turbinate, the ostium. Here is the ostium. So identify all these structures. Usually this is 1 to 1.5 centimeter above the choana, near the superior turbinate. And after this, so once on both sides you see, using endoscope, identify all the normal structures. After that you use the adrenaline soaked cotton patties for vasoconstriction, so that, because this is a very important part of your step of the surgery. Otherwise there will be oozing unnecessary. So one should spend time in decongestion of the mucosa of the nasal cavity by putting in these patties and keeping it for 10 to 15 minutes. And usually most surgeons become restless and take it out very quickly. So what you should do is that you pack them and then you start doing some other work. Like if there is a live surgery, then you start explaining the instrument or the radiology, or if it is not a live surgery, then you start taking out the flap, the fat from the thigh, or the facial lata from the thigh. So that if you do something, then you will allow this adrenaline soaked patties to work sufficiently, and there will be good decongestion. It should blanch. Then only you will save a lot of time in the surgery. So good 10 to 15 minutes exposure of this should be there. After that, you should plan whether you want a nasoseptal flap or not. So what are the indications for nasoseptal flap? If the pituitary tumor is very large, or you suspect some other pathology, like if you suspect a craniopharyngioma, which is an intradural lesion, whereas pituitary tumor is extra-arachnoid. Meningioma is also extra-arachnoid. So if you do good surgery, then you are not likely to rupture the arachnoid. And if you don't rupture the arachnoid, there is less likely that you will have a CSF leak. So nasoseptal flap should be used only when you suspect a CSF leak. Otherwise, don't plan a flap. So large lesion, recurrent lesions, intradural pathology, in those cases you can plan flap. Otherwise, the flap planning is not required. You can go for middle turbinectomy of one side. The other side, middle turbinate can be lateralized to get the space. Binostril approach is advisable. Now, a little bit about the nasoseptal flap. What should be done in nasoseptal flap? There is an uppercut which starts from the sphenoid ostium, and then you about 1 centimeter of the superior nasal mucosa should be left behind, because this will preserve the olfaction. There are olfactory fiber here. So in the uppercut, you leave about 1 centimeter of the posterior septal mucosa, posterior part. Anterior part, there is no nasal olfactory fibers. So there you can turn it superiorly and go like this. This is the inferior cut, which goes around the choana. And if there is an extra, if the defect is large, then you can take even the floor of nasal cavity. So the flap can be of different type depending upon what is required. So uppercut, saving the olfactory epithelium, and the lower cut, and the vascularity of the nasal septum should always be saved. The spinopalatine artery goes in between, anterior face of the sphenoid sinus, there is an artery here. So if you use bad flap, if your incision goes from here, then you might injure the pedicle of the flap. So carefully, just above the choana, you make an inferior cut. The upper cut should be just below the ostium and saving the spinopalatine artery, and also saving the olfactory epithelium, which is there in the posterior part of the nasal septum superiorly. Various types of flap can be used. At times, even in the simple pituitary, the mini flap is enough. Mini flap is extends up to the anterior margin of the middle turbinate. So it is on the nasal septum, but how do you recognize up to the anterior margin of the middle turbinate? If you make the anterior cut on the nasal septum, this will be a mini flap, which is enough for most of the pituitary tumor. But if patient is a child or there is a large tumor, in that case you might have to go for traditional flap or an extra large flap. In extra large flap, you go much more anteriorly, you go in the floor of the, so don't take only the nasal septum, but you can also take the mucosa of the floor of the nasal cavity. So extra large flap can be taken, or you can take the bilateral flap also. In a child, when you think that the flap in the craniopharyngioma in a child is not enough, in those cases you can take bilateral nasal septum flap also. Rescue flap, in which only the superior cut is given, and then superior and anterior cut, and then you mobilize the mucosa, and if required, then at the end of surgery you can make the inferior cut. And so if there is no CSF leak, then you can just leave it like that. There is nasal morbidity associated with the removal of mucosa can be avoided. So just give a superior cut and anterior cut and mobilize the mucosa, take out the bone and opposite side mucosa. It is a rescue flap in which the cut is made and then you mobilize it. And this is a mini flap in which only the posterior part of the nasal septum mucosa is taken, because otherwise also you need to remove it, because the posterior part of the nasal septum need to be removed to make it binostril approach. So rather than just damaging it, you can use a flap which is mini flap, the posterior flap, rather than a classical flap in which the anterior cut comes at the skin mucosa junction, so much more anteriorly. So only a posterior nasal flap can be used. So how long the flap should be? How to identify? You can find out the length of the flap required. So what is the length of flap? From the margin of the ostium. So line coming from the ostium to the posterior margin of the sphenoid sinus here. So this is the length. So the amount of the flap should be slightly larger than this length, from ostium to the sphenoid sinus posterior margin. So calculate the margin and then length, and then, so if the patient is less than 10 years, then the nasal septum is usually not well developed. But after 14 years, it is good developed. So in between 10 to 13 years, you should be carefully watching how much you require. If it is less, then bilateral nasal septal flap can be taken. In the technique, you again identify the ostium. Here you have taken a flap, and then after taking a flap, again identify the sphenoid ostium, enlarge it inferiorly, and remove the posterior nasoseptal bone, nasal bone, as well as the mucosa to make it binostril, and remove the bone anterior to the sphenoid sinus. To go for good removal of the sphenoid sinus, see, this is the sphenoid sinus. This is the posterior ethmoid air cells. So to have a good exposure of the sphenoid sinus, you need to remove the posterior ethmoid air cells. So remove the posterior ethmoid air cell. This will allow you to station your endoscope here. Otherwise, your endoscope will stain very frequently. So remove the posterior ethmoid air cell. One is that it will allow you to station your endoscope nicely. Extra space is created to station your endoscope. And two, to allow the visualization of the whole of the sphenoid sinus, you need to remove the posterior ethmoid air cells. And at times, not in pituitary tumor, but when there is a CSF rhinorrhea in the anterior and the lateral. So that is recess, anterior lateral recess of the sphenoid sinus. If there is a leak, here, you can find out that you need to remove the posterior ethmoid air cell. You need to remove the posterior margin of maxillary sinus and the medial margin. So unless you remove this, then otherwise you will not be able to take your instrument to plug the leak which is coming from the lateral recess, anterior and lateral recess of the sphenoid sinus. So if the leak is from here, then you need to remove the anterior face of the sphenoid sinus. You need to remove the posterior wall of the maxillary sinus and medial wall. Then only you will be able to take your instrument towards this site and expose the whole sphenoid sinus widely. Most important cause of less tumor removal is removal of less of the anterior wall of the sphenoid sinus. So wide exposure of the anterior wall of the sphenoid sinus and maybe posterior ethmoid layer cells are essential to find out all these structures. And if you are not finding these things well, that means there may be some septa left, or there may be a 180 cell which is preventing the optic prominences to be seen. So if you remove the whole anterior wall and posterior ethmoid cells, then you will find all these prominences like optic prominences of the optic nerve, the prominence of the carotid prominence. So the prominence between optic nerve and carotid will be optico-carotid recess. So this is lateral optico-carotid recess. This is medial optico-carotid recess. This is tuberculum celli. This is plenum sphenoid, and this is the cellar floor, clival recess. The opposite side, the carotid prominence. Okay, optic protuberance, and the bone between the two optic prominences is tuberculum celli here. So here The lateral opticocarotid recess, if you drill it, this will represent the anteroclinoid process. Intracranially, the medial opticocarotid recess, if you drill, will be the middle clinoid, and when you whole of the bone is removed, this is plenum sphenoid, tuberculum celli, optic protuberance, carotid protuberance, which is just like a C-shape. So carotid in fact anteriorly is more closer. So the chances of carotid injury is either anteriorly in the sphenoid sinus or posteriorly. Here in the cavernous sinus, it is just like a C-shape. So it goes little away. So chances of injury is either anteriorly hood or posteriorly here. So you should be careful, and while you drill here, you use diamond drill and use C-shape and paintbrush like technique. So here it comes more closer to the midline, here also. So these are the places where you can injure. Or when you use Carrison punch, you can take a bite in the carotid artery, and so don't use Carrison punch when you remove bone over the carotid artery. You just make a papery thin, drill it, and then using a fine dissector, just remove the bone when it is axial. So don't use Carrison punch. If you have to use it, then don't bite it. You just break the thin bone. Now, after removal of the bone, you will find the dura. So coagulate the dura, because there may be vessel in between the two layers of this periosteal layer and meningeal layer. There may be venous lake. So just coagulate it. Those people who want to go for extracapsular dissection, they don't coagulate, because then both the layers they fuse and it is difficult. In those cases, you have to just cut the periosteal layer and leave the meningeal layer inside. And in the pituitary transposition also, you don't have to coagulate. Otherwise, it will be difficult to separate the two layers. Otherwise, normally coagulate it and make a T cut in the lower part. So this is the cellar, whole cellar. So only in the inferior part you make a cut in the dura and make another cut here, or maybe two cut here. If you make a cut superiorly, there may be premature protrusion of arachnoid, and the complete tumor excision may become difficult. So if you need to go for transposition, you should not. If it is required, then go only for unilateral removal of the outer layer. That is, outer layer is the endosteal layer. The inner layer, you leave it, that is the meningeal layer, and in between you will find the vessels like the inferior hypophyseal artery. So if you go for total transposition of the pituitary, then you will injure both the inferior hypophyseal artery and the venous drainage. So there will be, most cases will go into panhypopituitarism. So one side, if you sacrifice the vascularity, then there is no problem. So just on one side, cut it, and in between the two layer, there are ligaments, pituitary ligaments are there. So cut those ligaments. There may be a little bit of bleeding, and you can coagulate one side inferior hypophyseal artery, but not both sides. Because if you go bilateral transposition, means bilateral mobilization, then almost all cases will go into panhypopituitary. Another important anatomical thing is that in the pituitary fossa, there will be two layers of this covering on the pituitary. One is the periosteal part of the dura and the meningeal. But towards the medial part of the cavernous sinus, there is only one layer, that is meningeal layer. So this is more likely to get injured and have bleeding. It is a thin wall, whereas here it is double layer. And the cavernous sinus, you know, is the results from splitting of periosteal layer and the meningeal layer. And in the lateral wall, you have the nerve. Okay, so if you are not able to listen, please let me know. After making a dural incision, you have to remove the tumor. So when you remove the tumor, you remove tumor from the posterior side first. So posterior part you remove, then you remove from lateral side towards the cavernous sinus on either side, and in the last you come anteriorly and superiorly. If you do it reverse way, then the arachnoid will descend premature and the whole tumor removal will become difficult. So, and how do you make out that the whole tumor has been removed? There is a full inversion of diaphragmatic celli with the arachnoid. So, uniform descent of the arachnoid in the cavity which is created by the tumor. If it is there, then it is a good tumor removal. And initially when you are removing tumor, there may be some bleeding and oozing, but once you remove the whole tumor, the bleeding also automatically stops. So complete cessation of bleeding is one indication. Another indication is that the arachnoid should descend uniformly. If there are multiple pouches, loculations, that means there is some amount of tumor remnant left in that loculations. Or the arachnoid is not falling, that means significant amount of residual tumor has been left out. You should be able to recognize the normal pituitary, which is because of the vascularity, it is more pinkish, and this is a firm tumor which is plastered on usually on the diaphragmatic celli superiorly, and it is resistant to suction. So usually it does not come out in suction unless you are very harsh and apply too much of suction. So normal pituitary is pinkish. It has a vertical longitudinal vessel running on it, and it is firm, which is resistant to the suction. So, and I have already told you that if there are multiple loculations, that means the tumor has not come out totally. There may be some pouches of the tumor. If you just open these loculi by applying a force by 2 micro instrument on one side and another side, the tumor will come out. So uniform descent, short video. Pituitary tumor. You should be able to see that sphenoid sinus is very well formed. This is the tumor. The normal pituitary is superiorly displaced and also on the surface, anteriorly, posteriorly. Most of the time it is at the periphery. Okay, so this you should, you should be able to find out where is the carotid, whether there is some encasement. If this is a post-operative, post-operative CT scan showing a complete excision. This is pre-operative, showing tumor, post-operative complete tumor excision, and these are edited videos. This is removal of middle turbinate using a monopolar cautery, and then using a scissor, removal of middle turbinate. Then this is raising of the flap, making an inferior cut, anterior cut, raising the flap, sparing the superior 1 centimeter, the posterior superior mucosa. Now this is the bone. The bone of the nasal septum has been removed, the posterior portion of this bone. And now you find a owl eye, one eye here, that is ostium, and then this is the rostrum. So removal of anterior wall of the sphenoid sinus. Now the cellular drilling of the tuberculum celli. So after thinning out of the bone, just using a Carrison punch, not biting it. After exhale, you can just remove, peel off, and then using a bipolar cautery, cauterize it. Otherwise, there may be some bleeding. The cut in the inferior portion. This is the whole dura. So cut has been made only in the inferior, vertical cut, and then a T. Then tumor removal from posterior side. So first from posterior side, then from lateral side towards the cavernous sinus. One instrument is retracting, another may be sucking, and the arachnoid, which comes as bulging, can be retracted using patties, cotton patties, and gently. Now see, the whole arachnoid has bulged uniformly, suggesting that the whole tumor is out, and then hemostasis achieved, irrigation, fat, and then nasoseptal flap has been applied. So nasoseptal flap applied, and then in the end you apply a glue. So that is the end of the surgery. If you have to go on the opposite side, supposing this is a tumor, don't come from the ipsilateral nostril. Come from the opposite. If it is on the left side, come from the right side nostril. This is the septum, and use angled instrument. So if you come from the opposite side, there will be better angle, and use angled tip instrument. So you will be able to reach the extreme of the tumor margin there. So this is how you can remove. Otherwise, many people struggle in reaching this side. If you come from here, it will be difficult to reach because the angle is less. Whereas a better angle if you come from the opposite side, and using an angle tip instrument, you will be able to reach the lateral most margin of the tumor. I told you there can be two types of resection, extracapsular or intracapsular. Extracapsular resection should be done when the lesion is small, microadenoma or even macroadenoma, but not very large. And usually if this is a functional tumor, in functional tumor, the whole tumor excision is required. Otherwise, the hormone producing tumor will produce problem. So in other tumors, even a small bit of tumor, if it is left, does not matter. But in functional, the whole thing should be removed. So extracapsular excision, there are more chances of complete tumor excision, but there are deficiency. There are more chances of endocrine deficiency also if you don't do it well. So small lesion, functional tumor, you can go for extracapsular, or there can be something in between. You go for internal decompression first, And then when the tumor becomes very small, then you go all around the capsule and take it out. So mixture of it. Very big tumor, very large invasive tumor, you cannot go for extracapsular excision. So you can take a combined approach also. Capsule is nothing but it is a pseudo capsule, which is a normal compressed gland, a pituitary tumor tissue, which is usually non-functional. It is a fibrosed gland. So there are high chances of tumor excision if you go for extracapsular dissection, and it should be used in non-invasive, usually in functional pituitary. The chances are of good tumor excision and hormonal remission, because the no tumor will be left, so therefore better hormonal remission will be there in a functional, non-invasive functional pituitary tumor. In rest, otherwise you can go for intracapsular excision. There are ways to find out which one is capsule. It is just a non-functional fibrosis of the normal gland, which is known as pseudocapsule. Usually it is light yellow or orange, whereas the capsule is tough and it is smooth. The gland normal tumor is soft in most of the cases, and normal gland otherwise, because of the increased vascularity or because of the vessels on it, is resistant to suction, or it can be detected by fluorescein intraoperative because the normal pituitary will be more vascular and will show more fluorescein compared to tumor or capsule. Or you can use intraoperative MRI to find out how much has been removed. So, I mean, in summary, if it is a small tumor, you can go for extracapsular dissection, take out the whole tumor intact. If it is a large tumor and soft consistency, then initially tumor excision piece by piece meet intracapsular, and then the whole pseudocapsule can be resected intact. Large but soft tumor is soft. So large tumor, but tumor itself is very firm. In that case, you go for tumor and pseudocapsule resection piece by piece. It is difficult to take out the whole capsule, large tumor. If you try that, then there will be more chances of bleeding by the cavernous sinus, or you can produce the nerve injuries and more chances of CSF leak and more chances of producing endocrine deficiencies, because more of the normal pituitary you will be removing in a large tumor if you go for extracapsular dissection. Now, if there is a CSF leak, you can use different kind of technique, overlay technique or underlay technique. So this overlay or underlay is not in relation to the dura, but it is in relation to the bone. So if it is above the bone, then it is overlay. If it is under the bone and between the dura, then it is underlay. And if it is subdural, if it is beneath the dura, then it is subdural or intradural. And combined technique can be used in which there is overlay, underlay, and intradural or subdural graft also can be put in to fill the cavity, or there may be obliteration. So different technique of repair of CSF leak can be used, or multi-layer closure, in which here, see if the tumor has left the large cavity, then you put in a fasciolata, which is little larger. It is inside the dura and outside the bone, and the cavity has been filled up with the fat. You can also put in some cartilage or the bone just like a gasket-like technique. So multiple fasciolata, fat, bone or cartilage, and then again fat, and then vascularized nasoseptal flap can be used. So multi-layer closure, especially using nasoseptal flap, reduce the chances of CSF leak. This is the picture I have taken from Dr. Dandapani in the book, which is our book. It is very well written how to repair the CSF leak in a craniopharyngioma. You can put in fat if it is pre-chiasmatic, because the ventricle has not been opened. But if the ventricle has been opened and if you put in some small fat, it will float inside the ventricle and will block the aqueduct of sylvius. So if the ventricle has been opened, then a small fat should not be put in the cavity, left out cavity of the craniopharyngioma. If the ventricle has been opened, don't put in a small fat. If you want to put in a fat, it should be a large chunk of fat. Part of it should be outside and part of it inside, and you tag it outside so that it does not float and flow inside the ventricle. But if it is a pre-chiasmatic, then you can fill up that space with the fat if the ventricle has not been opened. So after putting in many layers and after fibrin glue, you can put the balloon or Foley's catheter, which can be supported by the posterior nasal septum. So behind the posterior nasal septum, you have to inflate the balloon. Then only it will, it will not allow the graft which you have put in to migrate. So fixation of the graft is required. Multi-layer graft, intradural, only fat. Fibrin glue should be in the end. It should never be in between the layer. So don't put in subdural fat and then put in fibrin glue and then another fasciolata, then fibrin glue. If you put in fibrin glue in between the layers, then it will not allow fibrosis and there will be CSF leak. So after putting in all layers, all 3 layers or multiple layer, in the end you put in the fibrin glue, not in between the layers, and then after that you put the balloon to support all these grafts or F-gel, so that when you take out this balloon or packing, then whole graft does not come out. Some F-gel can be put in after these glues, so that when you take out this balloon, it does not come out. There may be another technique in which you can just obliterate the cavity, put in graft everywhere, fat, and this is known as obliteration technique of CSF leak closure. So fibrin glue after all the layers have been put in. There are various corridors. You can go anterior to the...
Sir, you would like to take some rest and take questions?
Okay. I think 1 or 2 slides and then we take questions and then finish. Then later on,
okay, sir.
Complications we can take. So there are various corridors anterior to the chiasma and the artery, in between the chiasma and artery, in between the chiasma and pituitary, and just around the pituitary, posteriorly the tumor. Most of the time, the tumor gives the space to manipulate. And then there are extended approach, which I will not deal with. So I think we can take now questions, and after that we move at halfway. So I will stop share now. Stop sharing.
No, so be there, sir. If you are taking questions, good evening, everybody. Sorry for joining late. I was held up in a meeting, but I think sir has covered almost everything, whatever questions are asked. We have some questions, sir. Would you like to take it now, or would you like to take it after some five minutes break?
No, please.
Okay, so the first question comes from Dr. Amit Joshi, Himachal Pradesh. He says he wants to know what are the radiological criteria for determining the feasibility of endoscopic approach and assessment of complete or incomplete resection.
Radiological criteria
For determining the feasibility of endoscopic approach.
That means you are asking whether what cases are suitable for this.
Yes, sir. Yes, sir.
There should be good sphenoid sinus. It should not be a conchal type of sphenoid sinus. If that is there, then you have to use navigation, and you should be experienced endoscopic surgeon. After doing some cases, then even in conchal type of this, you should take. If there is a infection, paranasal sinus infections are there, that is a relative contraindication. Some people say that you can treat the sphenoid sinus, sinus infection, and then go ahead also. So infection is also one of the relative contraindication of feasibility. If there is a firm type of tumor, then in the beginning of your learning curve, you should try avoid, or you should have beforehand that you are likely to have problems. That means MRI T2 hypointensity. If you find, then this tumor is likely to be formed, and you might have some difficulty in this. If both carotid are very close to each other, kissing carotid, then you cannot go. If the tumor is extending lateral to the neurovascular bundle, that is lateral to the carotid or lateral to the optic nerve or chiasma, then these are not suitable for transsphenoid approach, even whether it is endoscopic or microscopic. Or if there is associated edema, brain edema, there is no cap. Usually in between a tumor and the brain, there is a cap, brain cap, which is known as. So if there is a cap between the vessel and the tumor, that means you can dissect vessel very well. There is encasement of the vessel, encasement of the optic nerve, or the tumor extending lateral to the optic nerve and superior. These are relative, not relative, these are contraindications for transsphenoid surgery.
Thank you, sir. Very well explained. He has got second question, second part of the same question. Per operative assessment of complete or incomplete resection, I think you told Diro should bulge uniformly.
Yeah. Good arachnoid bulging uniform. If you find multiple loculations, that shows that some residual, even few millimeter of tumor may be left. But if the whole cavity, the arachnoid is not bulging, this shows that significant amount of the tumor has been left out.
Thank you, sir. So we move on to second question now. I hope Dr. Amit is satisfied with his answers. Dr. Muifazil Kodar from Chittagong, Bangladesh. He wants to know the management of CSF leakage. I think the last part of your slides explained everything. You can explain it, sir, again.
Yeah, a small little leak can be just, if there is just little bit, there are grading of CSF leak. A small leak, you can just put in even fat, or even these non-absorbable, even Surgicel, very small leak. Otherwise, if there is a ventricle has been opened or a large cistern has been opened, that is high flow leak, these are known as. So in high flow leak, usually you go for multiple layer closures, including the vascularized nasoseptal flap, facial fat, and if the defect is more than 1.5 to 2 centimeter, then you can use a bone also. because otherwise the support is not there. There are controversies. Some people do not like bone, but some says, and I personally prefer using bone as a gasket technique. In between the fascia lata, if you put in bone, then it seals very well, especially in the large defect. So multiple high flow, multiple layer closure, small leak, even fat is good enough. And if you are sometime, if the ventricle has been opened, very rarely you can put in some lumbar drain. This is also controversial. Some people do not like, but I like if the ventricle has been opened, then you can put in lumbar drain for some time, 5 to 7 days.
Thank you, sir. The third question is from Dr. Shamim Ahmed Gahati. He wants to know, he wants you to share the basics of neuroendoscopy CSF set, neuroendoscopy set used for pituitary for beginners.
Basic pituitary set?
Yes, sir.
I think the endoscope of 18 centimeter long, normal, which can be used for lumbar and cervical surgery also. Then you need some simple instrument, pituitary curette, angled blunt curette, which are normal instrument which are used in microscopic surgery also will be used for endoscopic surgery. So no special things are required except that the endoscope of 18 centimeter. I use endoscope of 30 centimeter when I use telescope holder also at times when there is a long surgery. Plus you need to have some scissor, scissor which can, angled scissor which can cut dura to the side, and then for dural opening, I use, what is that name? Knife? Capablanca knife is a good thing. Angled scissor. Then bipolar forceps, angled bipolar forceps is also quite useful, which you should purchase if you want to go for this surgery.
Dr. Shamim, hope you are satisfied. The next question comes from Dr. Rakesh Gupta of Indore, sir. He wants to know whether we have used any artificial dura for CSF leak.
Yes, yes, we have used. It is available with us. We have used artificial.
Okay, sir. So the next question comes from one of our senior colleague, Dr. Muthukurma from Madurai. He wants to know, how do you identify and preserve the pituitary stalk in giant pituitary adenoma?
Yeah, normally pituitary stalk is not seen except in craniopharyngioma. Craniopharyngioma, you see pituitary stalk very well. But giant pituitary tumor stalk is not seen, but you can see the normal pituitary which is plastered superiorly onto the diaphragmatic cell. But the stalk is not seen because you are not inside the arachnoid. This is, stalk is not visualized.
Thank you, sir. As of now, only these questions are there. You may please continue, sir, or you may take rest and then continue, sir.
I think I continue.
Okay,
so,
sir.
Thank you, sir. Thank you, Professor Muthukumar, sir.
Sir, there is a question from Dr. Suresh Sankla.
Okay, okay. Sankla, sir. Yes.
Yes, sir. Yes, sir. Yes, sir.
What is the question, please?
It's not in the chat box.
Acha, I can read it.
Sir,
Okay.
Sir, he has complimented you for impressive talk as usual. Do you use any specific technique to,
sir, I am grateful to
descent in the cellar?
Professor Sankla, sir, and Professor Muthukumar, sir, very senior surgeons. Thank you, sir. I am grateful.
Sir, his question is, do you use any specific technique to facilitate tumor descent in the cellar?
I think sir must be asking that some Dr. Kasam use that cotton swab. I don't use anything except I use two instruments, one suction and another blunt curette, through which I take out the tumor also. So one instrument I use it for retraction of the arachnoid and tumor, or showing me the tumor. So one instrument also can be used as a retractor, the another uses as a suction or as a dissector or curette. But the curette has to be blunt. It should not be sharp, especially towards the carotid in the cavernous sinus.
Thank you, sir. We don't have any further questions, sir. So,
okay,
please
so I think, we go ahead with. Is that all right?
Yes, sir.
Yeah.
Yes, sir.
Okay, so regarding the A's and the pituitary surgery, the aperture, anterior aperture is small in patient less than 2 years. So especially in craniopharyngiomas less than 2 years, this may be a limiting factors. And the sinus pneumatization starts at 3 years of age and completes at 10. So less than 10, it may not be well developed. Septum also less than 10 years may not be good developed. We have already discussed that even up to 13 years of age, the nasal septum may not be well developed. So you may require bilateral side nasal septum if the defect is large. But the intercavity distance does not change with the age. So even at a very small age, the distance between the two carotid arteries are usually not a limiting factors. So another thing which is very important in very large tumor excision, so one limiting factor which Professor Sankla once illustrated very well, the one is that incomplete anterior wall of the sphenoid sinus removal. Another is if you don't remove the tuberculum celli and part of the plenum very well, then you will not be able to remove. See, you can make out that when you are coming from here, unless you remove this part of the bone, you may not remove or cut the dura here. If you remove the bone, then you can retract with suction or any micro instrument. All these things, soft tissue can be retracted well, and this tumor can be removed. Otherwise, this bone will prevent you from taking out part of this tumor. So part of the supracellular pathology tumor, especially if it is firm, will stay there if you don't remove the tuberculum celli or the plenum. So this is what I wanted to stress by using this diagram also. So that should be done. Now regarding the results, the surgery is quite effective and safe in most cases, whether you use microscopy or endoscopy. For small lesions, whether you use microscopic approach or endoscopy, both are equally good. But for large lesion where you require a better visualization of the side or lesion extending laterally towards the cavernous sinus or supracellular extension, in those cases endoscope is better. Because visualization with the endoscope is better, therefore you can remove more and more safely. And the results in terms of hormonal remission or endocrine deficit are better with the endoscopy, or the extent of the tumor resection in the large tumor are better with the endoscopy as compared to microscopy, especially for large lesion. For a small, both are equally good. Complications rates are almost same with microscopy and endoscopy. So these are pre-op and post-op complete excision in one of our case. Now the advantage with this diagram, we can know that if you go transsphenoid, there is no manipulation of optic pathway. Otherwise, if you come transcranially, then you will be manipulating the optic pathway. Normal brain retraction will be required. And one thing I have already talked, that the normal gland is usually pushed superiorly. So if you come transcranially, then you come through the normal pituitary gland. So chances of going into the hypopituitarism or new pituitary hormone deficit will be more in transcranial surgery compared to when you come transsphenoid, because here the first thing which comes is the tumor rather than a normal pituitary. So there are advantages of transsphenoid approach, and especially endoscopic this thing. One of the recent series from Jaipur by Professor V.D. Sinha et al. Shows that the chances of, the chances of complete excision in endoscopic surgery is higher compared to microscopic surgery. The chances of CSF leak is less, chances of diabetes insipidus is less in endoscopy, and the risk of reoperation is less in endoscopy. Infection, sinusitis is also less in endoscopy compared to microscopic surgery. In another large series of more than 250 cases, in which 140 patients were done by the endoscopic approach, they also were the opinion that for microscopic and endoscopic approaches both are safe and effective to treat pituitary adenoma. But for more invasive adenomas and larger lesion, endoscopic approach may be better. Although the difference was not statistically significant, but there was tendency that therefore they use that it may be useful because you are able to see better. So therefore you can preserve the normal pituitary gland much more better, and the tumor excision, also complete tumor excision chances are also better. But there are complications associated. This is what I like to prefer. See, you should not always say that everything is good. There are complications and you should know what are the complications and how you can avoid them. So there are sinonasal complications which should be dealt with after surgery. You just don't leave patient like that. You have to ask these patients to go to the ENT surgeons and go for good debridement and use normal saline spray and irrigation after surgery. Otherwise, there will be crust formation, there may be sinusitis, there may be adhesions, and a lot of complications, nasal complications. There may be diabetes insipidus, transient. Most of these cases have transient, which improves after some time, but some of them may have permanent if you have not identified the normal pituitary and then injured this CSF leak, epistaxis. If you use monopolar cautery and short segment large vessel septal artery have coagulated with monopolar only, or there is infection or visual deterioration, though rare but may occur. Incomplete tumor excision, especially if there is a large tumor and you have not removed the tuberculum celli or the part of the plenum, which will allow the tumor to fall. There may be cranial nerve injuries, especially if there is a cavernous sinus invasion and you have been very rough, try to take out most of this tumor from this cavernous sinus, then you may produce temporary cranial nerve deficit, delayed or even early hyponatremia, hydrocephalus, especially if you have invaded the arachnoid and there has been some leak of blood in the arachnoid. So some subarachnoid bleed, if it is there, there may be delayed hydrocephalus leak, which you should be aware of and treat accordingly. New or worsened hypopituitarism if you don't identify the normal pituitary. Pseudo aneurysm if you injure the carotid and there is excessive bleeding. So if there is excessive unexplained bleeding during surgery, and if you have suspicion, then you should go for early angio. Otherwise, you can miss the pseudoaneurysm and there may be delayed rupture and patient may die. Vasospasm, if there is some traction or spillage of blood in the subarachnoid space, or traction injury to the vessel, or excessive dissection of vessel along the inferior margin of the chiasma, or internal carotid artery injury, which is a disaster, but it does happen. And if you get time, then I have dealt very nicely the complications in skull-base surgery and how to avoid them. And if they occur, how to treat them in one of our book, which is coming in less than 10 days time. So it is very well written, a very big chapter on this. I think it will take a lot of time. CSF leak, the chances of leak, it is less likely when there are extra arachnoid tumor. So pituitary adenomas are extra arachnoid tumor. If you go for good tumor surgery, then and you don't injure the arachnoid, there is less likely to produce CSF leak. But in a large tumor, it may occur. And this is the reason that in pituitary adenoma, you don't see the stalk because it is extra arachnoid tumor. In meningioma also, it is extra arachnoid. So if you do very well, good surgery, then CSF leak may not occur. But if you violate arachnoid, there may be injury, there may be leak. If there is an injury to the dura when you take out the bone over the cubiform plate or the planum or tuberculum by using Carrison punch or even using a drill, and if you are rough. The large or firm tumor, you may violate the arachnoid revision surgery. Large intra-arachnoid tumor like craniopharyngioma, you are bound to have a, CSF arachnoid tear. There you have to be very careful. And if there is a perioperative leak, then there are more chances of CSF leak, premature descent of arachnoid when you are dealing first the anterior and superior part of the tumor, which should not be done. And if there is a CSF leak, you should suspect hydrocephalus. Delayed CSF leak could be because of raised ICP or hydrocephalus. So prevention is by preventing the dural tear or arachnoid violation, or you remove tumor from the inferior side first, and then from the lateral side, and then in the end from the superior side and the anterior side to prevent a premature descent of the arachnoid and CSF leak. If there is a leak, then you should use nasoseptal flap or multi-layer closure, or if there is a hydrocephalus, delayed CSF leak could be due to hydrocephalus or raised ICP, that must be addressed. Now visual deficit could be there because of the traction or trauma on the optic nerve or chiasma or dehiscent optic canal, and you are not aware, or using a Carrison punch onto the optic canal for bone removal. Don't use Carrison punch. Just use drill, diamond drill with good irrigation, or heat may also produce, may give rise to injury to the optic nerve. Or tumor removal and you have not separated the optic pathways from the tumor, traction may cause injury to the optic pathway. There may be overpacking of the sphenoid sinus, too much of fat. So what should be done when you pack the fat in the sphenoid sinus? There should be good pulsations. So if you find good pulsations of the fat graft, that is good enough. If there is absence of pulsations, could be because of overpacking, and then you may come across that the patient may wake up with no vision or vision deterioration. Or traction injury, when the septa is going to attach onto the optic canal, or the nasal speculum in the previous surgery was opened in the sphenoid sinus, which has injured the optic nerve or produced the hematoma, or there may be cerebral vasospasm because you have done too much of dissection under the undersurface of the optic apparatus, or you might have injured the superior hypophyseal artery or has caused traction on it, or there may be empty cella syndrome. When there is a large tumor, a lot of cavity has been formed. In such cases, I put in some graft fat. Otherwise, later on, the chiasma will fall in that large cavity which has been. So there may be delayed deterioration because of empty cella syndrome, and the chiasm may prolapse in that. So that you should be trying to prevent. Avoiding trauma to the optic pathway, preoperative knowledge of dehiscence or septa, or drilling under irrigation. Don't use Carrison punch over to the optic nerve. No traction on the nerve or chiasma, gentle packing, and there should be good pulsation. Arterial pulsation should be there on the graft. Nasal speculum should not be opened there, or the Foley's catheter or the catheter balloon should not be inflated in the sphenoid sinus. It should be there in the posterior nasal cavity, just behind the nasal septum, and not in the sphenoid sinus. Avoid traction on the vessel and use VEP or navigation to find out where the nerve are there, and if there are any chances of disappearance of these, then you stop there. Incomplete tumor excision, incomplete removal of the anterior wall of the sphenoid sinus is the most important cause of, so you remove only the part of the anterior wall of the sphenoid sinus. So you should go as lateral as possible, remove all anterior wall of the sphenoid sinus. Maybe you remove, and in most cases you remove the ethmoid sinus, posterior ethmoid ear cells. Or if there is a fibrous tumor, large lesion with cavernous sinus invasion, invasive tumor, lack of removal of plenum and tuberculum celli. I have explained that if you don't remove this, then the tumor, supracellular tumor, does not fall, and you may find a residual tumor there, or incomplete or uneven descent of the arachnoid. So if there is no uniform descent of the arachnoid, you should suspect that some amount of the tumor has been left behind. So take proper precaution, do the proper surgery by wide removal of anterior wall, sufficient removal of tuberculum celli and the plenum. In large supracellular tumor, look for residual. If there is uneven descent of the arachnoid, or you can take the help of navigation, especially in the early learning curve, or you can use fluorescein guided surgery or intraoperative MRI to find out whether some tumor has been left behind. And the surgeon experience is also very important. In the beginning of your learning curve, you can take help of experienced surgeon or do surgery under the guidance. To avoid or treat incomplete, you should have advanced navigation protocol of fluorescein guided surgery or intraoperative MRI or CUSA experienced surgeon, or combined technique may be used. Ophthalmoplegia or cranial nerve deficit, especially in tumors, when you are over aggressive, or you are doing excessive packing of the cella, or aggressive tumor excision. But usually these are temporary, and most cases they improve unless the surgeon has been very rough. Delayed symptomatic hyponatremia could be there because of the iatrogenic injury to the posterior pituitary, salt wasting syndrome, or adrenocortical insufficiency, hypothyroidism, hyponatremia because of the hypernatremia overcorrection or volume overload. There are two types of hyponatremia, could be because of salt wasting syndrome or SIADH in pituitary. You can differentiate. I think I skip it. Usually dehydration is there in salt wasting syndrome. Urine sodium secretion is very high in salt wasting syndrome. Vasopressin serum level is high in SIADH. Polyuria is there in salt wasting syndrome, and urea and creatinine are raised in this but not in SIADH. BP is usually low in salt wasting syndrome, cerebral salt wasting syndrome because of the cranial cause, or brain natriuretic peptide are increased in this cerebral salt wasting syndrome. In treatment also, both the condition treatment differs. Here you use 3% saline. In SIADH, there is a fluid restriction. I think, and there can be hydrocephalus if there is arachnoid tear and blood goes in the subarachnoid space. So avoid that. And if there is a hydrocephalus, treat it by the shunt. Sinonasal complication, I have said, if you have removed too much of mucosa, post-operatively you have not used proper debridement and use saline spray post-operatively, prevent infection. Diabetes insipidus also can occur because of compression or destruction or interruption of blood supply of posterior pituitary, and it should be prevented by careful handling of normal gland. So identify the normal gland by the texture, by the color, by resistance to suck, and by knowing pre-operatively by CT and MRI where the normal pituitary residual, normal pituitary is plastered. Normally it is rubbed onto the diaphragmatic celli or anteriorly or posteriorly placed. Intraoperative, you can use fluorescein or new pituitary deficit. If you don't identify the normal pituitary gland, it occurs less often in transsphenoid surgery, more often when you go for transcranial surgery, because there you come across the normal pituitary first. So there the chances of having a new hypopituitarism, which hardly we do now, except when the lesion is infiltrating onto the, there is a septal edema, encasement of the vessel or nerve, or the tumor is lateral to the neurovascular bundle. Otherwise, most cases can be treated by transsphenoid. Epistasis also can occur because of the infection, or you coagulate the short segment of the main vessel by monopolar. So use bipolar, coagulate the long segment, use nasal saline spray to avoid infection or crusting. If there is a carotid injury, then there are various methods, including the embolization and the endovascular treatment, or trapping or compression or balloon, different strategies. I will discuss that later on. Pseudo aneurysm, one should suspect if there is excessive bleeding during surgery. So post-operatively, after 3 to 6 weeks, you should go for delayed DSA. Vasospasm, if there is a violation of arachnoid and there's blood going there, infection or a seizure or direct vessel wall injury or electrolyte imbalance. Internal carotid artery injury is most devastating complication. It can also occur. There may be injury to the carotid artery, or there may be pseudo aneurysm which can rupture the bony wall overlying the ICM is usually less than a millimeter. So there is already a very thin wall, and if you avulse the septa, it can break. And in 22%, it may be dehiscent. So there may be wall dehiscent, or even if the canal is there, it is very thin. Bony sphenoid septum may insert onto this. I have discussed all these things, or using Carrison punch, okay, grasping the septa and then pulling that septa, avulging the artery in invasive tumor also. In treatment, I think this is better. So if there is a bleeding epistaxis, you can use hemostatic or cauterization, small bleeding. If it does not control, then you use packing. If it does not control, then you go for endovascular treatment or exploration. Trap it or bypass. If it is controlled, then don't satisfy. If you go for excessive packing, the bleeding may be controlled, but still, if the bleeding has been controlled, but if there is a new cranial nerve deficit or there is an altered sensorium because the blood may enter in the cranium, if the arachnoid has been ruptured, then the blood may go inside the cranium. So if there is altered sensorium or cranial nerve deficit, go for CT scan, investigate, and in these cases you may require endovascular treatment or exploration. But if by packing there is no cranial deficit or no altered sensorium, then you can admit and observe. If unfortunately you have a carotid injury, then one is that you put in endoscope in the opposite nostril. Your endoscope should be protected by the nasal septum. So just behind the nasal septum, so that there is no frequent swelling of endoscope. And two suctions should be put in both the nostril, which will deviate the stream of the blood away from the scope. And the nasal septum should also be preventing the swelling of the endoscope, so that you see it and then your suction will be helping. So this can be done by compressing the carotid in the neck, unilateral, and then from other side also for short period only, not for prolonged. And once you pack it, then after some time, by packing, the most bleeding stops. You can use microscope or endoscope, but after the bleeding stops, then you should investigate for pseudo aneurysm or for complete occlusion and all these things. And if possible, go for endovascular treatment. Nasal packing, never pack forcefully, gentle packing, and there should be pulsations. Otherwise, risk of deterioration of vision and also causing thrombosis or occlusion of vessel. Limitation of endoscopic surgery if there is a sinusitis. So these are, you can say, relative contraindication of transsphenoid surgery. Absence of pneumatization of the sphenoid sinus, very close position of the carotid artery, significant supracellular extension with small hiatus, means dumbbell tumor, relative contraindication, lateral extension, lateral to the neurovascular bundle, retrocellular, relative, brain invasion with edema. So if there is a cerebral edema associated, there is no cap in between the vessel and the tumor. And then also there is a possibility of vessel encasement. Firm tumor consistency, difficult cases, involvement of vessels, artery, or vasospasm, or encasement of the optic apparatus, or invasion into the nasal foramen. Down-sloping planum also, but this can be drilled, or you can use angled scope. Steep learning curve. So in the early learning curve, you should avoid difficult cases. So usually the learning curve takes about 50 surgeries. So if there is excessive angulation of planum, then it is difficult to visualize this part. So using an angled scope or drill too much of bone, that down sloping planum will help in doing the surgery. And then I think the best thing, if you have controversy, some people say the endoscope better, some say microscope better. So this can be explained that some surgery says endoscope are better, another are showing microscope. Is possibly the difference in the experience of the surgeon. So if you know endoscope better, only if you have crossed the learning curve, then only the results will be better. But if you are good at in the microscopic surgery, you can get equally good results. So, but if you don't know the endoscopic approach and then you use endoscope, then you are bound to get a poor results. In those cases, I think blaming endoscope is not a right thing to do. So this book within 10 days it is coming, and we have a good, we have chosen very expert endoscopic surgeon, and you will find, I think all surgeries, especially we have discussed every steps of surgery and complication avoidance, indications and contraindications. So these are also very important, how to select patient for proper surgery. So what are the good cases in which you should go for surgery? And all small detail of surgery has been discussed, how to avoid complication, and if the complication arise, how to treat them, have been discussed in the book very well. The Professor B.S. Sharma has helped quite a lot, and my friend Jitin. So I think to summarize, endoscopic endonasal surgery is increasingly being used for most pituitary. Pre-operative CT and MRI should be done to find out all details about the sinus, the septum, the position of the carotid artery, the normal pituitary gland, the optic pathway, the carotid artery, whether there is dehiscence or not, and where is the normal pituitary gland position. All these things you can know beforehand and during surgery. And these are indicated in most tumor except in pure intraventricular lesions. Various modern facilities like neuronavigation, especially in the early learning curve, is helpful. CUSA or these indocyanine green or bone CUSA that will cut only the bone and not the soft tissue. So all these modern technique helps, but absence of these things should not prevent you from doing most of the surgery. These are useful in only 10% in difficult cases, resurgeries. So you can leave those 10% if you don't have facilities. Binostril approach is better than uninostril. High definition cameras are good. And most recent approach favors the endoscopic approach over the microscopic, because the amount of nasal complication, blood loss, operating time, tumor resection rate, the better endocrinal and visual outcomes are better in endoscopic surgery compared to microscopic surgery in most recent series. Complications of CSF leak is a problem which you should be able to deal with in some cases, but not so much a problem in pituitary. It may be problem in craniopharyngioma. Nasoseptal flap has decreased the complications of CSF leak, and there are various complications. One should know the limits, and especially for beginners, proper case selection should be there, and use a modern navigation technique and using good post-operative care, especially management of the endocrine dysfunctions, and establishing a pituitary center of excellence. If one person is doing one surgery only, you are likely to get better results. Focus, residency, and endoscopic fellowship program. And if there are some problem, you should not hesitate in converting into the open surgery, and you can take help of your colleague, the ENT surgeons, and you can become better expert by attending cadaveric dissection, practice on model, and observation of live surgery. Although endoscopic transsphenoid surgery provides superior visualization, but one should convert to microscopic or combined approach if there are difficult cases in selected. And at times, multimodality treatment is better than going for aggressive treatment, especially if there's a giant tumor and more of cavernous invasion. So rather than chasing that tumor and producing cranial nerve deficit and more complication, I think it is better to go for surgical treatment combined with the radiotherapy, chemotherapy, and other things. So individualize the help, don't only go for chasing the tumor. I am thankful to my teachers and friends. Thank you very much. We can take now.
Thank you, sir. Thank you for the very elusive talk from every small detail of identifying the tumor, how to, whether it is fibrous or whether it is easily resectable, and selecting the endoscope, how to resect and how to deal with the complication, especially the second part, the dealing with complication almost like a textbook, whatever remotest possible complications also there you dealt very well, sir. Thank you, sir. If there are two more questions, sir, from one is from Dr. Ganesh, Chennai. He is asking, cutting the outer layer of dura only, will it cause venous bleeding from intercavernous sinus? Kindly clarify, sir.
Not intercavernous sinus, but at times there are venous lake in between the two. Usually, most of the time, there are two layers. You see, one is the endosteal or periosteal layer, and another is meningeal layer in the dura over the cellar floor. Laterally over the cavernous sinus, there is only one layer, there is periosteal layer. So if you are going for extracapsular dissection, then you have to cut only one layer. If you cut both the layers, you will not be able to do that. So it is only for extracapsular dissection. You need to, and also for mobilization of the pituitary transposition. Otherwise, for intracapsular dissection, 99% I coagulate it and I cut both the layers. And I go intratumor and make the larger tumor small, because we hardly get any small tumor except for the functioning adenomas. There you have to, you may use this technique. Otherwise, cut both the things. At times, in large tumor, if you only don't coagulate, then you may have significant bleeding. Correct.
Thank you, sir. Thank you for clarifying this. I hope Dr. Ganesh is satisfied. And the next question is from a very senior surgeon from Armed Forces. Group Captain Yadav sir. Firstly, he is conveying his congratulations for the elusive presentation.
Thank you.
And he says it was a detailed webinar with very useful tips of do's and don'ts. But he has a question, sir. In small residue, do you prefer to observe or a radiosurgery?
Yes. If it is a non-functioning tumor, just observe. Most of these cases, they remain like this for a very long period and you don't have to do anything. So non-functioning small residual, hold on, nothing. If it is a functioning tumor, then yes, because otherwise this will recur. So take it out.
Thank you, sir. And the next one is from Dr. Jitin Bajaj, who is an author of the book, which he is first of all thanking you and says it was a very comprehensive presentation. Thank you, sir. And Dr. Ganesh also says he wants to ask one more question, sir.
Yes.
Sir, at present, your indication for use of microscope.
I don't use microscope only in one case when I had carotid injury. Then the endoscope, I was not able to control the bleeding with the endoscope. So there I use microscope. If you have possibly VTOM, then you can. But I mean, there is no disadvantage of using a microscope. Microscope is not our enemy. So now I have only used once microscope after about, I think, 15 years, and that was carotid injury. Otherwise, microscope not required. Or you are, if you are disoriented in the beginning of your learning curve, if you are disoriented, you can use microscope, no problem.
I hope that answers your question, Dr. Ganesh. So there are no further questions, sir. I think the presentation was too elaborate. I think so people have understood more than all their doubts have got cleared. And thank you, sir. Thank you for taking trouble and then presenting the whole spectrum of how to do a pituitary endoscopy to detailed complication, how to deal with it. Thank you once again, sir. And we will welcome our viewers to please join us in the next webinars.
Thank you. And I thank Professor Swamy and Professor Shailendra Ratre. And I thank the sponsors of this, Deepak sir and his team. Thank you very much. Thank you.
Thank you, sir.
Thank you so much. Thank you, audience, for joining us today. You came in large numbers in spite of a working day, that is Monday. We got 389 attendance today with 7 countries and 37 logins from abroad. So thank you so much, audience. I'm sure you must have got benefited from yet another episode of the Professor Dr. Y R Yadav's neuroendoscopic surgery, and this time on pituitary tumor. This webinar was well coordinated by Dr. Shailendra Ratre and as usual by Dr. Narayan Swamy by their insights and questions. Thank you very much, Professor Yadav sir, for giving this opportunity to carry this webinar. We have been enjoying carrying this webinar for last 7 episodes, and we are looking forward to the 8th episode of Dr. Professor Yadav. Thank you very much, audience, for taking care of your patients in this COVID-19 pandemic. Keep supporting Health and You products. And this is Deepak Naik on behalf of Health and You signing off today and hoping to join you again in the next episode, which is the 8th episode of Dr. Professor Yadav's neuroendoscopic surgery series. Thank you. Good night.
Thank you. Thank you.
Thank you.
Thank you, sir. Thank you. Thank you, Ratre sir. Thank you, Swamy sir. Thank you.
Thank you, Mr. Nayak.
Thank you.